Well, I'm Dr. Jim Del Rosso, the editor-in-chief of the Journal of Clinical and Aesthetic Dermatology, which we affectionately and lovingly call the Green Journal. This is a peer-reviewed and index journal, which every month we strive to bring you exciting articles, interesting articles, clinically relevant information to you in dermatology. And I'm going to review the April 2026 issue, which is volume 19, number 4. And I'll start first with an article that's in the residence corner, right? And it's selecting and transitioning electronic medical record, EMR systems in dermatology, key considerations and opportunities for residents. Now, I recognize residents are usually not the ones that are picking out an EMR system for the practice or wherever they're doing their residency or when they're going into practice, but it's certainly important for them to be aware of that. That may come up if they're ever administratively involved or own a practice. But there's also times you transition from one EMR system to another. So this is written by Arvind Jadoo, a dermatologist who covers how you choose the right dermatology electronic medical record system. So, because there are general ones that dermatology might have to fit in with, which leave a lot to be desired because they don't necessarily address dermatology specific issues. What practices consider when changing an EMR system and the key considerations when transitioning, because they're not all created equal. And even within themselves, there are a lot of options on how they can be used. And when you're documenting, you want to make sure you're able to, in a facile way, document accurately the information as a clinician that you want to see in the medical record. That's not an automatic. You have to make sure you know what's going on. Then there's a letter to the editor exploring the therapeutic potential of topical honey in atopic dermatitis. So I always wonder if I see a bee landing on a flower, right? If it knows that the honey it's created has a lot of different applications, and here being topically applied for atopic dermatitis. I doubt the bees know about that, but they're creating something that is very beneficial. This is a letter to the editor from Aileen Park, Lana Almatrad, Leo Wan, and uh, Dr. Peter Leo, always involved in these integrative and different methods of approaching how you can manage a disease state like atopic dermatitis over and above the classic recommendations, skincare, moisturizers, cleansers, and medications. And they talk about what topical honey may be able to bring to the table. I think it's worth looking at. It's not something that I typically run to right away. I'm usually pretty conservative in what I utilize with some of the standard measures, but my mind is always open to new possibilities. When I see Peter Leo's name, I always know that was a lot of diligence put into that particular article, and we thank him for that. The next article is one that I was involved with, along with Dr. Graham Lichman and Diego Ruiz da Silva, Dr. da Silva, severe nail psoriasis and early psoriatic arthritis. Illustrative cases confirming that severity of disease is not solely dependent on the extent of body surface area. So, to summarize, there are two case reports where patients had very prominent uh, nail involvement. They both had psoriatic arthritis. There was subtleties in evaluating that. They had very limited cutaneous involvement other than the nail disease, and they were significantly psychosocially affected. Depression, embarrassment, things that are really, really significant in their day-to-day life over a period of time. The nail involvement, there are great photographs before and after. Both patients were very very successfully treated with very rapid response of the symptoms and the visible appearance of the nail unit involvement with bimekizumab injections. Within a few months, dramatic improvement and essentially complete clearance by 3 months in both cases. So that was very important to look at. But key points here was that severe disease, these patients were rated as severe. Number one, because the involvement of the nail unit really affected their ability to function, both socially, psychosocially, and physically. A lot of pain, a lot of discomfort, nail unit involvement visibly and physically with these thickened nails that made it hard for them to work with their hands. They had pain if they easily hit those nails on a surface that would create a backward force. So that physical involvement, but there was pain and joint stiffness related to the psoriatic arthritis itself, which you want to stop in its tracks before they get permanent joint damage. So they had essentially no cutaneous psoriasis other than the nail unit involvement. So you would be thinking, well, the body surface area, they can't qualify for moderate to severe. They were severe on the basis of not being able to function psychosocially and certainly physically and having psoriatic arthritis. So they qualified for a severe rating. Very important to document all of that. And the article also goes through how to assess the nail unit in terms of involvement and how what you see reflects what's going on within the nail unit. So it covers a lot of ground. We're very proud of this article. I would strongly recommend, reading it and clip and saving it because it's something I think you'll go back to, read it a few times, and you'll pick up something new every time. I'm very proud to say that as one of the authors. I don't necessarily say that on every article that I'm involved with. I think very, very valuable on a lot of levels. The next article is by Nuri Adel and colleagues. It's on plant exosome injection, a new boost for post laser vascular repair. And we've had a lot about exosomes. And in this case, we're talking about plant derived nanovesicles that are related to the vascular system, vascular remodeling, and also helping normalize vascular abnormalities in post laser situations. And this is related to the endothelial behavior of CD31, a key endothelial adhesion and signaling molecule, right? It has to do with angiogenesis, the onset, vessel reorganization, and endothelial stability. And there are different exosomes, these plant derived nanovesicles, that help to normalize that. They looked at two different ones, Xylene and Glow exosomes, and the Xylene in this particular evaluation outperformed the other formulation. So it essentially was to look at utilizing these particular formulations that would help improve post laser treatment with microvascular remodeling. And I think for anyone that is interested in doing post laser surgery and looking at vascular repair, it's a very interesting article. It's early on in its development. This was tested on rabbit tongue models. So obviously, looking at whether we have that basic information to transcend it forward. And so far, so good. So if you're a laser individual and you're interested in knowing what's going on within the vascular system, that is a very, I think, very, very worthwhile read. Our next article is entitled Hispanic and Latino Ethnicity and Acculturation, Influences on Skin Cancer Prevention Attitudes and Behaviors. And this is by Luis Andrade, Dr. Luis Andrade, and colleagues. And it essentially addresses the fact that the Hispanic and Latino population is rapidly growing within the United States, and they project that by 2060, it'll be close to 30% of the overall US population. So, what they were essentially looking at is behavior patterns and how they may influence skin cancer prevention, photoprotection, and other issues in this particular population. And contrary to prior assumptions, I like how they word this. Contrary to prior assumptions, acculturation to United States culture showed limited influence on most sun protective behaviors amongst Hispanic and Latino adults. So, in thinking about this population, we might intuitively sense that, they tend to have darker skin. They may not think they need as much sun protective behavior because they're naturally protected. They don't necessarily use sunscreens regularly because of that. And that's not necessarily true. But socioeconomic disparities and occupational exposures are really what seem to make a difference, especially in high ultraviolet risk industries where they commonly work in agriculture and construction, where they're outdoors. I think about many of them that work in Las Vegas in the middle of the day. It's 112 degrees out, it's sunny, and they're, you know, doing some kind of agricultural work or construction work, getting a tremendous amount of exposure. It's very important that we make sure that they need good photo protection and sun protection practices as much as anyone else, and not to assume that they have more inherent protection. The same would be true of any darker individuals, African American individuals, people from India, people from the Middle East, from Asia, where they think that they have natural protection, so they don't need to use photoprotective behaviors and sunscreens. The next article is by Roger Seeley and Shannon Shirashebu, and this is from Dr. Seeley's practice in Des Moines, Iowa, where he's been there for several years and has very active surgical practice. And this is on optimizing surgical tray setup and instrument selection in dermatologic surgery. It's extremely important to organize your surgical tray. Why? Because you want to facilitate access to the instruments and supplies that you need off of that surgical tray. And you want to do it without risking injury from something sharp that may be on the tray. So if things are randomly located or very sloppily put on the tray, it would be very easy to go to get something and get stuck by a needle or or something that's pointing on that tray. You want to maintain a very organized surgical tray. This is shown within the article, in the pictures that is shown, and also to look at selection of instruments. Why you're choosing certain instruments. You may have different trays for different purposes, like a punch biopsy tray, a standard excision tray, a Mohs surgery tray, if that applies to your practice. So it really goes through some of those important considerations and addresses efficiency and waste reduction. So when you see Dr. Seeley and his colleagues put together an article on surgical setup or how to arrange surgery, dermatologic surgery in your practice, I would certainly pay attention to it. The next article by Eric Dominguez, and it's one that Eric and I talked about that I was happy that he submitted. I knew about this particular case because he had discussed it with me, is the treatment of periorificial dermatitis with topical roflumilast 0.3% cream, an illustrative case report with rapid onset and prolonged remission. Perioral dermatitis is very tricky. We still don't know exactly what causes it. It can create a fair amount of symptomatology, even when visibly it doesn't look to be very, very severe, right? It typically involves the perioral area with sparing around the vermilion. It could also extend onto the cheeks and the periocular area, and it could be very difficult to control. There are a variety of different therapies that have been used. Oral tetracycline agents are often needed, but it's nice if we can control it with a topical agent and not necessarily have to give a systemic therapy. In this case, Dr. Dominguez used topical roflumilast 0.3% cream, which happens to be under the brand name of Zarive, and found an excellent response. There has been some suggestion that PDE4 inhibition, which this therapy does, might be helpful in this particular disease state. And it certainly was in this case. You could see in the photograph, the patient had a very, very quick response, and it stayed away for 7 months. I think it responded within the first week, within 5 to 7 days that it was gone. And going out as long as 11 months, it did not recur. And Dr. Dominguez and I discussed this case, and he went back to make sure that the patient did not have any further recurrences or need to go back to the therapy. So it responded and stayed away. It's one case, right? And we want to collect more and more of these cases with a variety of different therapies because it can be difficult to treat and it's often very symptomatic for these patients. So, single case report, but an important one. Another paper by Madeline Lilich and other colleagues is low dose isotretinoin. And this was an evaluation of 21 cases, an option for treatment of scalp and facial rosacea. So, facial rosacea, certainly not a surprise, but sometimes you will see extrafacial rosacea involvement on the scalp has been reported, and sometimes these cases can be difficult. So, what came out of this was that the patients needed more, especially for clearance of the scalp lesions. So they received low dose oral isotretinoin. The mean daily dose was 72 milligrams, right? Is what they show here. The range was from 40 to 120. That's not necessarily a low dose as far as the daily dose, but they used it over a relatively short period of time, uh, typically about 4 months or so, and then would stop. So the idea was to get the disease under control and then not necessarily to continue the isotretinoin long term. So this was an interesting approach for patients that do have that extrafacial involvement on the scalp that tends to be refractory. Utilizing oral isotretinoin for rosacea in selected cases is not a new concept, and this was one time that it was applied in a very short duration to achieve a goal of clearing, especially those scalp lesions, but sometimes the face lesions are more stubborn. Now, another article that we have Albert Zoe as the lead author and Dr. Todd Schlesinger as the senior author, The Pipeline of Devices and Aesthetics, What is Left? And this is a review article that talks about modern aesthetic care and looks at different methods that we have, neurotoxins, fillers, and they also discuss exosomes and microneedling, walking through what's available and where we might lead on to future development. So also post-burn skin regeneration is discussed, which I think is very important because we deal with that in dermatology, but we don't talk about it very much. So again, I want to thank Dr. Schlesinger for leading very important review articles within the journal. And then the final article, an analysis of thyrotropin levels in patients with non-scarring alopecia, a single center retrospective comparison study. by Simona Alamari and colleagues. Susan Taylor is on this paper, as well as some others. And I think this is a very important paper because we think about thyroid involvement, certainly with alopecia areata, right? But when people have hair loss, we think about thyroid involvement. So thyroid testing is typically done. This looked at over 1,400 patients and found that there really wasn't a major difference. Okay. So what they ended up saying here was there was no significant difference in TSH distribution across all the different non-scarring alopecia subtypes, including when stratified by low normal and high normal levels. And so that was very, very important. It tended to have um, dysregulation of those thyroid levels in some patients with telogen effluvium, but it didn't really show any type of means of separating from all those different groups. Certainly, thyroid testing is important, but I think in your mind, you really have to be looking at what you're actually thinking is necessary for the patient. If you get it on all the patients, that's certainly fine, but the expectation is the yield is likely going to be relatively low, right? And that's about it. I think that sums up what we have in this April 2026 issue of the Journal of Clinical and Aesthetic Dermatology. Some important information there covering a variety of different areas. And I'm excited to get to May. Thank you for joining us.